So, first of all, why are we having this workshop today? Well, as I mentioned previously, we have some funding from the federal government. First of all, we had funding to develop and now to disseminate the Australian Guide to the Diagnosis. This is obviously a work in process, and we really would love your feedback if you notice any problems with the guide or have any suggestions in which way it could be improved. So we want to familiarise you today with the guide. We want to go through how to use the guide in a clinical session. And what we're going to do is run through a number of components of the guide. First of all, taking an alcohol history. Secondly, assessing the physical and facial features. Thirdly, and most importantly, assessing for neurodevelopmental impairment, because really the crux of this diagnosis, whether or not there are physical or facial features, is severe, pervasive neurodevelopmental impairment. And then formulating a diagnosis and developing a management plan. But really, just to put this in perspective, let me just give you the example of one child that I saw in my clinic. First, when he was aged 3, and he came with his father and stepfather. He'd been born to an alcohol-dependent woman at the age of 19, and she drank very heavily, to the extent that the father got custody from birth. He was born preterm, a bit low birth weight. He was a bit irritable and fed poorly, and he had a single seizure in the neonatal period. Subsequently, his development was slow. He was slow to speak, his motor development was slow, he had emotional lability, he had difficulty with social skills. He had some physical features. He had a squint. He had, even at an early age, he was labelled as having ADHD. He was a very hyperactive child with risky behaviours. So even at the age of 3, he was climbing onto roofs, running onto roads. He had difficulty taking in complex instructions. He repeated his mistakes, so each morning he'd put his clothes on top of his pyjamas, and his mum would have to take them off and explain that he had to take his pyjamas off before he put his school clothes on. And he was, from a very early age, labelled disobedient. And quite often these children are labelled as disobedient or having willful behaviour, when indeed they've got behaviours that they really have very little control of. He was expelled from preschool, and I think those of us around this table will acknowledge that many of the kids we see are those who are expelled from preschool. So really already you have extreme behaviours coming to the fore. And by the time I saw him later, he was failing in primary school and had been suspended from primary school. He was a child who had microcephaly, and not very clear to see on this picture, but he had the 3 sentinel facial features, which we'll discuss later. So really that one does wonder, he's in a stable environment from birth, and yet significant behavioural learning and other difficulties from a very early age. And so one does wonder, what is the future for these children? And we know now from longitudinal studies that as these children go up, they continue to have difficulties. Many of them fail academically, many of them fail to live and work independently, and there are certainly higher rates of mental health problems, substance abuse, contact with the justice system. And really that's one of the reasons that we need to get in as early as possible with an accurate diagnosis and try and identify the needs and indeed the strengths in these children, so that we can give them the best possible outcome for the future. One of the difficulties we have is that we have very poor data. We have very few population-based studies. These are very expensive to do and very time-consuming. We do have some studies. We did a study in the Fitzroy Valley in Western Australia of 45 very remote communities, where we found that around 20% of children of primary school age had fetal alcohol spectrum disorder, with all the problems that I've described. More recently, Carol Bauer led a study in Banksia Hill, which is the youth detention centre in Perth, and they found that 36% of children in juvenile detention had fetal alcohol spectrum disorder. We're doing some national studies with reporting from paediatricians to try and estimate the rate of newly diagnosed cases, and I'll just tell you a little bit about that. This is an active surveillance system whereby all paediatricians in the country should receive a card every month, And if any of you paediatricians in the audience are not receiving a card, do tell me, because this is a very good way of getting a snapshot of what's going on in the country. We ask paediatricians to report any child newly diagnosed under the age of 15, and if they report a child, they will then be sent a link to a brief questionnaire to provide de-identified data. We then classify these cases according to the guide. And over the period 2015 to 2017, we had 433 notifications of newly diagnosed cases. So it's certainly out there. And remember that it's not just paediatricians who are making this diagnosis. We received most of those questionnaires back, and we verified over 250 cases during this time period. Now, the cases that were excluded were either duplicate cases, or they didn't meet age criteria, or were outside the time of the study. But what does this tell us about what we're seeing in Australia? Well, about a fifth of these cases had fetal alcohol spectrum disorder with the characteristic facial features. We'll talk about that a bit later. 80% didn't. And those who didn't were more likely to be diagnosed in specialist clinics, presumably because those clinicians felt more confident in making that diagnosis. About 60% of the children are Aboriginal, and that's despite the fact that many Aboriginal communities in Australia are not serviced by paediatricians. The age of diagnosis, the mean age was 8.5 years. So really that's quite late, but not surprising, because that's the age at which these children start to struggle at school academically, and their behavioural problems become a problem at home and at school. 63% boys. 60% of these children live in out-of-home care. Only 20% live with both parents. And again, in our clinic, and Doug might like to comment, but about 70% of the kids that we see in Sydney are in out-of-home care, whereas in Fitzroy Crossing, 100% almost of the kids we see are living with their parents. When we looked at the diagnostic process, we found that about 20% of paediatricians were using a standardised way of asking about alcohol, 60% were using some sort of photo analysis, and about 30%, or a bit more, 35%, were having genetic testing. Over 85% used some sort of standardised assessment when approaching the neurodevelopmental assessment, and about 9 out of the 10 domains that we recommend be assessed were assessed in about a third of the children. Most of these reports came from the specialised FASD diagnostic services. These children had a significant impairment. In fact, you can see that almost a fifth of them, or over a fifth of them, had microcephaly, and 20% of them had affected siblings. So although that's lower than the previous study we did in 2000 to 2004, it's still of concern that there are missed opportunities for prevention. So if we can pick up and diagnose a child in a family, we may be able to prevent the birth of a subsequent affected child. Well, we did quite a lot of work in Western Australia in health professionals, and we found that health professionals did not ask about alcohol use in pregnancy. They didn't advise or refer for treatment. They didn't know how to diagnose fetal alcohol syndrome, it was at that stage. Certainly our surveillance data suggests underdiagnosis of fetal alcohol spectrum disorder. There were limited opportunities for health professional training. There's also a perceived lack of evidence-based treatment, and I think that's something we might touch on briefly. Although this workshop has not got an emphasis on treatment, we believe that the important thing is doing an accurate assessment to identify the needs and the strengths of those children, and then plugging them into the appropriate service, rather than thinking that there's necessarily going to be specific treatments for children with this type of brain injury. However, why we've asked April and Sue and Vanessa to be part of this workshop is that the strategies that they've developed for managing the practical problems that children and adults have are extremely important. And finally, there's been a lot of confusion internationally because of the different international diagnostic criteria. The guide that we're going to be talking about today is used very similar to that that's used in New Zealand, Canada and Scotland. So really there's a large bulk of the population now using this guide. Finally, there's a lack of health services offering assessment and diagnostic services. Now, that is not to say that any of us believe that we need hundreds of fetal alcohol spectrum disorder assessment services. What we really need to do is upskill child development services to think and ask about this diagnosis, general paediatricians, community paediatricians, psychologists, allied health professionals, really just to increase capacity across the board. So back in 2010, Carol Bauer and I tendered successfully for some Department of Health funding to develop a diagnostic guide. We did a systematic literature review, we got input from clinicians across the country, and we developed a guide which was then trialled in clinical practice and modified. In 2016, we made further revisions to this guide, partly because the Canadians by then had published their diagnostic guide, and we felt that we wanted to align with that guide, particularly with the categorisation of the diagnosis, which we'll go into later. So what this guide contains is information about diagnostic criteria, categories of fetal alcohol spectrum disorder, how to assess alcohol use, neurodevelopment, facial features, growth, how to formulate a diagnosis, how to discuss the diagnosis and develop a management plan, and how to report the diagnosis. And it contains a number of forms, and I'm not going to go through these in details, but there are forms for the clinicians, such as a diagnostic assessment form, and you can use this form or modify it according to your clinic needs. There's also some information for parents. So what are the implications of a diagnosis? What happens after the diagnostic assessment? How should they use the management plan that you've developed for them? Who should they contact for more information? And we refer all our patients to the National Organisation for FASD, No FASD. So coming back to the criteria, what are the three key diagnostic criteria? Prenatal alcohol exposure, critically severe pervasive neurodevelopmental impairment, and with or without sentinel facial features. And the guide contains several algorithms to help you work your way through a diagnosis. And for example, the diagnostic algorithm in children over 6, have they got prenatal alcohol exposure? Is it absence? Is it confirmed? Is it unknown? If it's confirmed, have the children got neurodevelopmental impairment? Have they been fully assessed and not got neurodevelopmental impairment, or have they been too young for assessment? Have they got no diagnosis, or are they still on your radar as a child who's at risk because they've had inadequate assessment? If they do meet neurodevelopmental criteria, have they got 3 sentinel facial features or not? If they have alcohol exposure, neurodevelopmental criteria, whether or not they've got the 3 facial features, they still fulfil the diagnosis of fetal alcohol spectrum disorder with fewer than 3 facial features. If they have the 3 facial features, they fulfil criteria for fetal alcohol spectrum disorder with the 3 sentinel facial features. So we've really simplified this so that we're calling the diagnosis fetal alcohol spectrum disorder, and we're acknowledging that it either does or doesn't have these 3 sentinel facial features. So FASD with 3 sentinel facial features is what we used to call fetal alcohol syndrome. FASD with fewer than sentinel facial features is what used to be called partial fetal alcohol syndrome or alcohol-related neurodevelopmental disorder. So I think this is it's a simplified way of sort of classifying the diagnosis, but we find that it's less confusing for parents that the children all have fetal alcohol spectrum disorder with or without the physical features. Now, why wouldn't they have the physical features? Well, as we know, it's the first trimester in which the teratogenic effects of alcohol exposure may be manifest in either abnormal facial features or structural defects. In the second and third trimester, the brain continues to develop and there may be neurodevelopmental impairment at exposure during any time of the pregnancy. You'll note just here where it says fetal alcohol spectrum disorder with 3 facial features, that if you have the 3 facial features and neurodevelopmental impairment, the diagnosis can be made in the absence of alcohol exposure. But as all of you will know, this is a diagnosis still of exclusion. We need to make sure there are not other causes for the child's neurodevelopmental impairment. So the guide contains this list, which on the left says diagnostic criteria, and on the right is the 2 categories: fetal alcohol spectrum disorder with and without 3 facial features. This is the summary form I mentioned, which you'll be seeing later in the day, which we find very useful in the clinic just to summarise which domains of impairment are affected, which domains are impaired, what the alcohol exposure is, what the facial features are, what other diagnostic tests have been performed. Really making this diagnosis is like we approach any child with neurodevelopmental problems, a full history. Obviously, in this case, we're interested in confirming prenatal alcohol exposure, but we're also interested in other prenatal alcohol exposures. Has the mother taken other drugs? Has the mother had severe diabetes or hypertension in pregnancy? We're interested in the child's developmental history and also in the environment in which that child was brought up. Was there significant early life trauma or neglect? And finally, we need to look carefully at the child physically. Is there another reason for this child's neurodevelopmental problems? Have they got some sort of hereditary problem? Have they got a neurodegenerative disorder? Have they got neurofibromatosis or tuberous sclerosis? Has there been another teratogen that could have been involved, such as dilantin? Has the child got visual or hearing impairment? We need to measure the growth, even though it's no longer required for the diagnosis of this disorder. But obviously we're interested in the child's growth. We're particularly interested in the child's head circumference. And most of us in our clinics routinely exclude fragile X, do a chromosome microarray, and look for other causes of neurodevelopmental problems. So the guide is freely available. It can be found at this website on the hub. And we do have some freely available e-learning modules which are currently just being updated. So they have been online previously, and we'll certainly let you know when they're available, which really takes you through the whole of the diagnostic process.